members, seniors, my dear colleagues, and all the delegates present over here. Myself, Dr. Krishna Jasani, Senior Resident in the CFM department. I would like to extend a warm welcome to everyone gathered here for this CME on non-communicable diseases from warm to tom, combating non-communicable diseases across the lifespan, organized by CFM Department, All India Institute of Medical Sciences, AIIMS Rajkot. In this CME, we have an exciting program lined up with expert speakers who have proven the expertise across the various aspects of non-communicable diseases. The organizing committee extends a warm welcome to all the speakers and resource persons for the CME. I request all of you, please switch off your microphones. Now, I would like to request Dr. Vivek Kumar Sharma, Professor and Head of a CFM department, to deliver the keynote address and opening remarks. Over to you, sir.
Thanks. So let's start the CME program. The title is very apt. What we can see over is communicable disorders are increasing all over the world. But what is necessary is that warm to tom approach is extremely important for all over the world, but especially for the Indians. Because if we see the Southeast Asian population, especially the Indians, if I talk about specifically, what do we see that they have a higher centripetal obesity, thin, lean body mass, thinner bones, and they have a very high level of the non-communicable disorders, including, that's why we all never say about the MI. We say in Indians as the CADI, coronary artery disease in Indians. It is specifically so because we have a very high propensity for the malnutrition, for the undernutrition, and for the overnutrition all over the world as it is increasing, and also a very high level of the infective disorders that are occurring within the body. These things are marking us very apt for this title that is given over here, that we have to find the strategies that can be applied right from the warm towards the end of the life, that is in the tom. If we apply all these techniques, we are having a very good faculty members who are going to deliberate about this topic from different point of views, who are going to say about these topics. If I talk about the sum up of all the things that they are going to say, that we have to find about the strategies that are applicable throughout the promotive, preventive, curative, and rehabilitative approaches. All of them have to be combined together, and they have to see to it that all these things are not limited only to one generation. They are not overburdened by the genetic predisposition, but that strategies, they are applicable throughout the life of the persons and throughout the world. So that includes the lifelong prevention as well as the intergenerational focus. It should not be focused on a single generation. The progeny should also be protected against it, and it should have the integrated health systems. All the activities as we see in Ayush, Ayurveda, Unani, homeopathy, Siddha, whatever works along with the allopathy, we should try to we should comprehend upon it, and we should try to take the help of that, and then we can develop some strategies that can be applied throughout the life from warm to the tom of any person. And we should focus on the socio-economic and environmental determinants that are extremely important. As I have just told you, that environmentally we are having more of the infective disorders as compared to the best, as towards to the more developed societies. And also all these strategies should be sustainable. It should not be limited only to the CMEs and other various programs that we are conducting all over the world, but they should be applied, and they should be applied all over the year or so, and they have to be there. The strategies that are sustainable, we have to see to it that sustainable means can be developed about that. So with these words, I would like to invite over here Mr. Ankur Pratap Singh ji, who has come over here also to deliberate about these things. And he is also the Deputy Director Admin of this institute. So I'll hand it over to him to say his Ashirvachan in Hindi.
Sir, thank you very much. Thank you very much, Dr. Vivek, for inviting me over here. and for conceptualizing this idea of non-communicable diseases, which seems to be an important part of our life. And I look forward for a wonderful and knowledgeable session ahead. Thank you, sir. Thank you very much.
Thank you, sir. I'll hand it over to Dr. Krishna. Please.
Thank you so much, sir. Now, we shall now begin with today's deliberation. In the next upcoming 2.5 hours, the expert deliberating in today's CME will share their expertise across various aspects of the non-communicable diseases. So, without any further delay, we shall now begin with our first speaker. Now, I cordially invite our first speaker, Dr. Venkatesh Karthikeyan. He serves as a senior resident in the Department of Community and Family Medicine at AIIMS Patna. He holds prominent positions including Publication Director and NCD Chair at World Medical Association (JDN) and the National Conveyor for the Antimicrobial Resistance at the Indian Medical Association. Additionally, he is the Director of Medical Education for the Commonwealth Medical Association and the National Vice President of the Indian Association of Community and Family Medicine. Dr. Venkatesh has authored more than 25 publications in reputed international and national journals. Today, Sir will deliver the session on global and national situation analysis of non-communicable diseases. Over to you, sir.
Thank you so much, Dr. Krishna Jasani. Is my screen visible? Am I audible and is my screen
Yes,
visible?
sir.
Yeah.
Okay, okay. Thank you so much once again. So, first of all, a very good afternoon, everyone. Thanks to the head of Department of Community and Family Medicine, the Deputy Director, sir, Dr. Kripal, sir, Dr. Krishna, and the whole of CFM department. I would like to thank, and also at the same time, I would like to congratulate you for organizing this timely session, because parallelly, the United Nations high-level meeting for non-communicable diseases is going on this week, and in a very timely fashion, this meeting is being organized. So I congratulate and thank you all for giving this opportunity. So in the next few minutes, I'll discuss in brief about what is the global and national situation of non-communicable diseases. As we all know, non-communicable diseases are also known as chronic diseases. They tend to be of longer duration, and that's how it got its name. And they are a result of combination of various factors like the genetic factors, physiological factors, environmental factors, and behavioral factors. If we see the global burden, WHO estimates that NCD kills at least 43 million people in the year 2021 alone. That is around 4.5 crore people across the globe die due to NCDs, which is equivalent to 75% of the non-pandemic related deaths. And 18 million of this 43 million deaths is a premature mortality, that is death before 70 years of age. And of all these premature mortalities, 82% of premature mortalities comes from low and middle income countries like India. So our country and other low and middle income countries, they have a highest burden of non-communicable diseases. And of all the NCD deaths, 73% of deaths come from LMICs like India. This is just a comparison of how trends in NCD related mortality is there across different regions of the globe. So if you could see, I'll just turn on my pointer. Yeah. So if you could see, the highest burden in the year 1990 was in high income countries and high socio-demographic index countries like Switzerland, Germany, and Singapore. But the trend is gradually changing, and you could see the top burden is now faced by Southeast and East Asian countries. And if you could see, with regards to number of deaths in India, there is 457 deaths per lakh population related to non-communicable diseases. And if we talk in terms of percentage, 55% of total deaths in India is due to non-communicable disease. And you could see in dark red color in Southeast Asia and other high-income countries, the mortality and burden of non-communicable diseases is much more higher. If we take the year 2021, cardiovascular diseases accounts for most non-communicable diseases. The top four NCD diseases include cardiovascular disease, cancer, chronic respiratory disease, and diabetes. So here cancer accounts for 10 million deaths, chronic respiratory disease accounts for 4 million deaths, and diabetes accounts over 2 million deaths, including chronic kidney disease, which is usually caused by diabetes. So these four group of diseases, that is cardiovascular, cancer, chronic respiratory disease, and diabetes, these four constitute 80% of all premature non-communicable deaths, that is deaths before 70 years of age. And in the meeting which was happening last year in the UN, in the United Nations, it was discussed that 1.3 billion adults are living with hypertension. That is 20, and of these, only 20% have blood pressure under control. Similarly, 800 million adults are living with diabetes in the world, and 1 in 5 person in the world have the risk of developing cancer throughout their lifetime. And with 20 million new cases are coming up every year, of which 400,000 cancers are seen in children. 3.7 billion people suffer from oral diseases, and more than 674 million people are affected by chronic kidney disease. So this is the latest picture we have with regards to global scenario, and what are the top NCDs which are causing the deaths related to NCDs. We often tend to ignore mental health, but we should always keep it in mind that mental health are also coming under the banner of non-communicable diseases, and it includes anxiety, depression, and psychosis, which is affecting close to 1 billion people worldwide. So around 100 crore people across the globe are suffering from mental health conditions. And suicide is the third leading cause of death for those between 15 to 29 years of age group. NCDs and mental health are very closely intertwined. If you see mental health conditions, they contribute to increasing burden of NCDs, and people who are living with mental health and neurological conditions, they tend to have increased risk for non-communicable diseases. With regards to the top causes of deaths across the globe, if you see in 1990, let us take the first 5 top killers. So cardiovascular diseases and neoplasms, only two non-communicable diseases were in the top 5 reasons or causes for mortality across the globe. But now, if you take the scenario of 2021, out of top 5 reasons for death, top 4 reasons, first, fourth, and fifth are due to non-communicable diseases. And this is the global scenario. What is in India? In India, if you see, in 1990, if you take the top 7 causes for death, only two NCDs are there. Whereas in 2021, over a span of 2 decades, the scenario has completely changed. Out of top 7 different causes of death, 4 causes of death are due to non-communicable diseases like cardiovascular disease, chronic respiratory disease, neoplasms, and diabetes and CKD. So this clearly reflects the growing burden of non-communicable diseases, especially in our country. And this is again a comparison between global and national scenario. If you see across the globe, 65 percentage of deaths are due to non-communicable diseases, whereas in India, 55 percentage of deaths are due to non-communicable diseases. But what is more concerning to me is that the annual change in percentage for non-communicable disease related death is 0.34 across the globe. But if you take India, 1.3% of there is an annual percentage change of 1.3 percentage for the NCD related death, which is highly concerning. Again, this shows that there is uniformly equal burden of non-communicable diseases, that NCDs are increasing across the different states of India. And among those NCDs, what are the top NCDs which are causes for death? If you take the global picture in 1990 as well as in 2021, the top 3 NCDs are cardiovascular diseases, neoplasms, and chronic respiratory diseases. In India, the scenario is little different. The neoplasms are in third place, and chronic respiratory disease are in the second place. So the other reasons for death include diabetes, digestive disorders, neurological disorders, other NCDs, substance use, musculoskeletal disorders, skin diseases, and mental disorders. So these are the top 10 or top 11 NCDs which are contributing to total number of deaths, growing number of deaths in the country. Just sharing few slides from the recent National Family Health Survey 5, which is 2019 to 21 data. Here we could see that 21.3% of Indians are hypertensive. That is, they are having a systolic blood pressure of more than 140 or diastolic more than 90, or taking the medicines to control blood pressure. 21.3 percentage of women and 24 percentage of men are hypertensive. And if with regards to diabetes, 15 percentage of men and 15.6 percentage of men and 13.5 percentage of women are having a blood sugar of more than 140, or they are taking medicines to control the high blood sugar levels. So we have discussed about the mortality. Now, a few slides about few points about DALI. So as you may be aware, DALI stands for Disability Adjusted Life Years, which is nothing but the sum of years lived with disability and the years of life lost. Globally, if you see, the distribution of DALI is again high in Southeast countries and high income and high socio-demographic index countries. In India, 55 percentage of the total DALIs are contributed by non-communicable diseases. Whereas if we see the global average, around 60 percentage of the DALIs are caused by non-communicable diseases. So, how are these non-communicable diseases caused? Why are they caused? The risk factors include behavioral risk factors, environmental risk factors, and metabolic risk factors. The behavioral risk factors include tobacco use, which also includes the exposure to secondhand smoke, and then unhealthy diets, including excess salt, sugars, and fats, harmful use of alcohol, and insufficient physical activities, or the various behavioral risk factors which may lead to non-communicable diseases. And if we see what are the metabolic risk factors, raised blood pressure, including hypertension, overweight, obesity, diabetes, and high blood glucose level, abnormal blood lipids, including high cholesterol, are all metabolic risk factors which may lead to non-communicable diseases. This most of us may be aware. But what most of us fail to ignore or fail to not pay much attention is the role of environmental risk factors like air pollution, in both indoor and outdoor air pollution, radiation, noise, land use patterns, work environment, and climate change. These are all environmental factors which may lead to development of non-communicable diseases. Now, a lot of work is going on in climate change related activities, and the intersection between NCDs and climate change is explored and addressed in the recent past. So this is one scope of area where we can one area where there is scope for a lot of work to be done. And with regards to the numbers for the risk factors in the global scenario, 1.3 billion tobacco users and more than 7 million tobacco related deaths occur each year across the globe, which also includes 1.6 million non smokers who are exposed to secondhand smoke. 2.6 million deaths occur each year, which are attributable to alcohol consumption. 35 million children under the age of 5 years are currently overweight, and 390 million children between 5 to 19 years old are overweight or obese, and the obesity in adults has doubled since the year 1990. Also, interesting to note, nearly 7 million deaths occur each year due to air pollution, and 99% of the population are exposed to unsafe air pollution levels. This is just the data from NFHS 5, which shows that around 23 percentage of men and 24 percentage of women are obese. And this is compared with the NFHS 4, which is 2015-16 data. We could see there is a clear rise of around 5 percentage with regards to the obesity or overweight. Also, a 38 percentage of men consume or use uh, any form of tobacco, and 18.8 percentage of men they consume alcohol. All these are directly contributing to the rise in non-communicable diseases, especially in our country. So it is not only about the mortality and the DALIs, it is also about the socioeconomic impact which we should be concerned of. So poverty is closely related and closely linked to non-communicable diseases. Vulnerable and socially disadvantaged people, they get sicker and die sooner than people of high socioeconomic status, especially because these people who are vulnerable and socially disadvantaged, they have limited access to the healthcare services. And the rapid rise in non-communicable diseases is predicted to impede the poverty reduction initiatives, whatever the government is taking to eradicate poverty. All it becomes a question mark because of this increasing non-communicable diseases, which comes with increasing costs, out-of-pocket expenditure. And this scenario is true in India also. This is one of my recent studies where we determine the out-of-pocket expenditure among patients with diabetic foot ulcer in Madras Medical College. Here we found that the median out-of-pocket expenditure is around 30,000 rupees, which is too high for a country like India. And of this, only 60% is towards direct medical costs, and rest 40% are towards loss of wages or transportation costs and other non-medical costs associated. Understanding the burden of non-communicable diseases, the World Health Organization has recognized this, and the Sustainable Development Goal has been framed in such a way that the burden of NCDs and premature deaths due to non-communicable diseases is targeted to be reduced by one third in the year 2030. And in 2019, the World Health Assembly extended the WHO Global Action Plan for the prevention of and control of NCDs, which is originally for 2013 to 2020. It has now been extended to 2030, and it called for the development of an implementation roadmap for the year 2023 to 2030 to accelerate process on preventing and controlling the non-communicable diseases. This is achieved with the help of 9 global targets with the greatest impact towards prevention and management of non-communicable diseases. So, a few words about what we actually do on behalf of World Medical Association. So, World Medical Association is an international organization representing physicians, and it was founded in our year of independence, that is 1947, with 27 countries, which met in the first General Assembly. Currently, we have a strength of more than 115 national medical associations, and the purpose of World Medical Association is to serve humanity by endeavoring to achieve the highest international standards in medical education, medical science, medical art and medical ethics, and healthcare for all people in the world. Out of different areas in which World Medical Association works, non-communicable diseases is a top priority in which WMA works. This we also have advocated for non-communicable disease-related things in the World Health Assembly, which happened in May 2025 in Geneva. I was a part of drafting the statements as well, and this statement, which we drafted and we released in the World Health Assembly, we have clearly stated that to achieve lasting progress, stronger commitments on holistic health system strengthening and investment in health workforce is needed. This includes commitment and one target on national workforce strategies with fair remuneration, occupational safety, and lifelong learning. So this clearly emphasizes how important it is for the governments to invest in health workforce. And this is a paper which I published 2 years ago, which was the stakeholder analysis for the hypertension management in the context of Indian public health system. Here also, we got a very similar finding. Our findings reveal that policymakers and program managers, they can lead this fight against hypertension and NCDs through a top-down approach. And for ensuring better performance of the healthcare system, health workforce is the obligatory pivot, and healthcare providers can be the point of convergence where the efforts made by different stakeholders, they converge, and they translate into results only through the healthcare workers. And it is very much essential that investments are made for strengthening the health workforce. This is just a table from my thesis, from my postgraduate thesis, which was on capacity evaluation of health and wellness centers in providing non-communicable disease services. So I have visited 21 different centers in my neighboring district, that is Jahanabad in Bihar. It clearly showed that not even a single PHC or health and wellness center had adequate manpower, which was recommended as per the Indian public health standards. That is the situation of manpower and health system in our country, and we need a lot of work is to be done. Though there are many initiatives which are taken by the government, like the Ayushman Bharat, like health and wellness centers, Ayushman Arogya Mandir. There are a lot of initiatives which are taken by the government, but still the distance we need to go is too long. We need to make more efforts in this direction, especially with regards to strengthening the health workforce. Also, we closely work with the World Health Organization, and we had a recent stakeholder consultation, and we participated in the second general meeting of the World Health Organization Global Coordination Mechanism on NCDs. Also, we contributed towards panel discussions, which was titled "Tackling the Determinants of NCDs and Mental Health Through Multi-Sectoral and Effective Governance and Collaborative Action." All this clearly indicates that NCD is not a one-person game or a one department's game. Okay, it needs multi-stakeholder approach. It needs support from the government, from the healthcare providers, from the civil societies, from the academia, from the research, from all various different partners needs to come together. Multi-sectoral approach is needed to tackle this growing burden of NCDs. So I had the opportunity of representing World Medical Association, and have been at the fourth Global NCD Alliance Forum in Rwanda, in Africa. There, with the support of Global Health Advocacy Incubator, we organized a session where a civil society-led advocacy for prioritizing domestic resource mobilization for NCDs was advocated. Again, we you know that the percentage of GDP which is spent in each country for health sector is very less. If I'm not wrong, for our country it is around 2.1, but we are targeting to achieve at least 2.5 percentage of GDP which goes towards the health sector. So, and how civil societies can play a role in this was discussed during that session. And again, these are some photos from my thesis, which shows that even common drugs like metformin and amlodipine are available in only or less than half of the PHCs in Bihar. Similarly, many services like estimation of lipid profile or oral examination was done in around half or less than half of the PHCs which I visited in Bihar. And whenever it comes to highest level of policy making, like the United Nations or World Health Assemblies, the role of civil society or the voice of civil society organizations are not given the importance it deserves. So we also advocate on behalf of World Medical Association that we need to include the civil society organizations in non-communicable related disease related advocacy. Also, we are trying to come up with different innovative approaches for tackling this growing burden of non-communicable diseases. So we have launched this initiative called Young Doctors Health Parliament. We did the first meeting in 2024. Thanks to Dr. Kripal sir from AIIMS Rajkot for supporting this initiative, which is an attempt to increase or to make the policy makers hear our voices. If you could see the deputy director of Indian Council of NCD division of the Indian Council of Medical Research was one of the invited speakers in that meeting, and we are trying to bring stakeholders from different domains and from different profiles together, and try to make our advocacy efforts turn into policies, so that the priority, though there are 100 priorities of government, NCD is a burning issue, and we are trying to take all efforts to to make the government realize the importance of non-communicable diseases and take actions accordingly. So to conclude, non-communicable diseases and mental health conditions, they prevent people and communities from reaching their full potential. They pose a heavy economic burden, and they limit the human capital development, which can undermine the sustainability of health systems, and they compound the cycles of poverty. So there is a need for whole of government and whole of society approach to tackle the non-communicable diseases. It is high time we recognize this growing burden of NCD. We sensitize all the relevant stakeholders about this burden of NCDs. We promote research for non-communicable disease-related domains, and we translate all our research findings into advocacy efforts. And ultimately, this should reflect in policy making. Thank you so much, everyone. Thanks to AIIMS Rajkot, Dr. Kripal sir, and Department of CFM for this opportunity. Thank you.
Thank you, sir, for this wonderful deliberation on situation of non-communicable diseases globally and in India. As a token of appreciation, I request Dr. Vivek Kumar Sharma, sir, to kindly present the memento to the Dr. Venkatesh. Sir.
Request Dr. Kripal Joshi.
Now I request Dr. Krupal Joshi to receive the memento on behalf of the Dr. Venkatesh sir.
Thank you, sir. Thank you so much, sir.
Sir, we will send you in a courier.
Thank you. Thank you so much. Thank you so much.
On moving forward, now I would like to introduce all with our second speaker, Dr. Kunal Devkar, Assistant Professor in Department of Pulmonary Medicine. Dr. Kunal has pursued MBBS, MD Pulmonary Medicine and DM in Critical Care and Sleep Medicine. He has total of 61 research publications, including 54 PubMed indexed articles with H index of 7 and 238 citations to his credit. He has also authored a book titled MCQ and Facts in Respiratory Medicine that is published by the Paras Publishers. And his special area of interest is critical care, sleep medicine, and metabolic syndrome. So today, sir will talk about multimorbidity of non-communicable diseases and metabolic syndrome, which is a rising epidemic. Over to you, sir.
So thank you very much. And I am Dr. Kunal Devkar, and for the next 30 minutes or so, we will explore as to what is multimorbidity, what is metabolic syndrome, and how metabolic syndrome acts as a gateway to multimorbidity. So let's just start with a case. So this is one of our patients which I saw yesterday in the OPD. So Mrs. XYZ, 52-year-old female, obese, teacher by occupation, and she came to us primarily for obstructive sleep apnea. And in addition to that, she had diabetes mellitus, hypertension, osteoarthritis, depression. So OSA, diabetes, hypertension, osteoarthritis, depression, 5 diseases. For obstructive For diabetes mellitus, she was consulting an endocrinologist for which she was on insulin. For hypertension, she was consulting a cardiologist for which she was on telmisartan and amlodipine. For osteoarthritis, she was seeing an orthopedician for which she was temporarily on painkillers but was advised knee replacement. And for depression, she was seeing a psychiatrist for which she was on antidepressants, SSRIs. So you see 5 different diseases and so many drugs, almost 6 medications and 5 different specialists or super specialists. So ironically, she was spending more time in hospitals than in her classroom. That was her work area. So this is what is multimorbidity. So in simpler terms, what is multimorbidity? Multimorbidity is the presence of 2 or more chronic conditions at a given point of time in an individual. And there are different definitions of multimorbidity, but the most commonly accepted is the World Health Organization definition, which says that multimorbidity is the coexistence of 2 or more chronic conditions in an individual. And these chronic conditions can either be any chronic infectious disease or any chronic non-communicable disease, or for that matter, even mental health condition. So why multimorbidity is important? And if you see, the numbers do matter. So this was a very big meta-analysis involving 126 studies, 15.4 million people spanning 54 countries, and which showed us that the global prevalence of multimorbidity is 37.2%. And if we see the region-wise distribution, South America leads with a prevalence of around 36.7 to 50%, followed by Europe, 37 to 43%, and then Asia, which includes India, has a prevalence of around 31 to 35.6%. And if we look at the analysis from the NFHS4 data, we see that the prevalence of multimorbidity in India is 7.2%, but probably this is an underestimation because NFHS4 included only 5 chronic conditions: asthma, anemia, obesity, diabetes, hypertension. So there are many more chronic conditions in addition to this. Also, the population was in the age group of 15 to 49 years, and we know that multimorbidity increases with age. So definitely India does have a substantial prevalence of multimorbidity. So the earlier notion that multimorbidity is a disease of the West or multimorbidity is a disease of the affluent is no more true, and we can see multimorbidity even in low middle income countries and low income countries. And if we look at the common diets or triads, that is the common 2 or 3 diseases which are associated with multimorbidity, then the most common diet is the existence of obesity and hypertension, and the most common triad is the presence of diabetes, obesity, and hypertension. So why multimorbidity is important? Now, forget about the numbers. Let's look at the human cost. So if we come back to our patient, she had 5 conditions for which she was on 6 medications and she was seeing 5 different specialists. So as the number of chronic conditions increase, the number of medications required for treating those diseases will also increase. That means there is an increase in pill burden leading to polypharmacy. So more the number of medications, more will be the chances of drug-drug interactions, which leads to increased adverse events, reduced compliance. Then as there are more diseases, the patient will have to consult different specialists. So multiple specialist visits are required. As multiple specialist visits are required, there will be more healthcare system visits, and this all will increase the healthcare expenditure for the patient. And as patient is suffering from so many diseases, it's but obvious that they may get mental health issues like anxiety and depression. So this is the reason why multimorbidity is so important. This is the reason why identifying and preventing multimorbidity is very important. And then you look, there is a cascade. This research shows us that the presence of diabetes, stroke, and MI at the age of 40 years decreases human life by about 23 years. That means 23 years of human life stolen by multimorbidity. And it's not just about mortality, there is also accelerated loss of function, accelerated loss of cognitive, accelerated loss of cognition, then there is functional decline, there is reduced quality of life, and there is need for complex treatments. So basically, with multimorbidity, with rise in the number of coexisting diseases, the treatment burden increases, but at the same time, the patient's physical, mental, and financial capacity decreases. And so now let's take a look at metabolic syndrome. So this is where it gets more interesting, because metabolic syndrome is a gateway to multimorbidity. We can call it as a perfect storm creator, or probably an orchestrator of multimorbidity. And why do we call so? Because if we see what is metabolic syndrome, so basically metabolic syndrome is high blood sugars, that is insulin resistance. So fasting blood glucose more than 100 milligram per deciliter. Then second is obesity, predominantly abdominal obesity. So waist circumference more than or equal to 90 centimeter in males, or more than or equal to 80 centimeter in females. Third is high triglyceride levels. So triglyceride levels of more than 150 milligram per deciliter, or a patient on drug treatment for elevated triglycerides. Low HDL cholesterol, also called as the good cholesterol. So less than 40 milligram per deciliter in men, or less than 50 milligram per deciliter in females. And hypertension, that is blood pressure of more than or equal to 130 by 85 millimeter of mercury, or on any treatment for hypertension. So if a patient has any 3 of these 5, then the patient is said to have metabolic syndrome. And so why, as we said, why metabolic syndrome is important? Because it acts as a gateway to multimorbidity. So how does it act as a gateway to multimorbidity? So we know that a patient who has metabolic syndrome is at an elevated risk of cardiovascular diseases. So metabolic syndrome leads to increase in the risk of cardiovascular disease by 2-fold. So an 100% increase in risk of cardiovascular diseases. Also diabetes. So as far as diabetes mellitus is concerned, metabolic syndrome leads to an increase in the risk of diabetes mellitus by 3 to 5-fold. So almost a 300 to 500% increase in the risk of diabetes mellitus. Similarly, now there is an interesting insight from the Framingham cohort. If we see in these patients, those who had metabolic syndrome but did not have obesity, they still had increased cardiovascular risk. However, those who were obese but did not have metabolic syndrome, they were not at increased risk of metabolic syndrome. So probably obesity is not that important, but what is more important is the metabolic syndrome, which leads to a cascade, metabolic cascade, which predisposes a patient to elevated risk of multiple diseases. And it's not only cardiovascular diseases, it's also metabolic syndrome also increases the risk of stroke by 1.6 to 2.2 fold. So almost 160 to 220% increase in the risk of stroke. Then chronic kidney disease, almost 150 to 260% increase in the risk of chronic kidney disease. And this cardiovascular, kidney and metabolic associations had become so substantial that the American Heart Association had to release a presidential advisory in 2023, and this advisory gives us guidance on how to detect and prevent this cardiovascular kidney and metabolic interactions. Apart from this, metabolic syndrome also increases the risk of obstructive sleep apnea, that is OSA, by 150 to 200%. It also increases the risk of non-alcoholic fatty liver disease by 200 to 300%. And we all know this, that of all the patients who develop non-alcoholic fatty liver disease, 20% of them will progress to non-alcoholic steatohepatitis. And of all the patients who develop non-alcoholic steatohepatitis, 25% will progress to cirrhosis. And of all the patients with cirrhosis, almost 7% will develop hepatocellular carcinoma over a period of 10 years. So that is the magnanimity of the problem with metabolic syndrome. Then vascular dementia, Alzheimer's disease, metabolic syndrome also increases the risk of Alzheimer's disease by 1.22 to 1.9 fold. Even cancers, metabolic syndrome is known to increase the risk of endometrial cancer. It is known to increase the risk of colorectal cancer, pancreatic cancer, liver cancer, bladder cancer, and breast cancer. And ultimately, metabolic syndrome increases all-cause mortality by almost 1.27 to 1.6 fold. So metabolic syndrome basically acts as a key that unlocks multimorbidity. So once you have it, you are not just at risk of diabetes mellitus or heart disease or kidney disease, but you are at a risk of all of them. And they may develop within months or years. So it is basically physical inactivity, obesity, particularly abdominal obesity, certain dietary factors, and genetic predisposition, which predisposes a patient to metabolic syndrome, and this metabolic syndrome in turn predisposes to various other diseases. But as every dark cloud has a silver lining, we know that metabolic syndrome is both preventable and also reversible. So how to prevent? So lifestyle interventions. This gives the introduction or marks the introduction for our next session, which is on lifestyle intervention. So I won't go into much details, but what is important is, as we said, obesity, physical inactivity are the main drivers of metabolic syndrome. So lifestyle intervention will include aggressive reduction in weight, increased physical activity, good sleep. And also, if any cardiovascular risk factors like hypertension, dyslipidemia are present, then managing those cardiovascular risk factors is very important. And if this is done diligently, then it is possible to reverse metabolic syndrome. Then there are many dietary approaches which have been advocated by metabolic syndrome, but what we can see from this study is it was the Mediterranean diet which was helpful in reducing all-cause mortality. It was helpful in reducing cardiovascular mortality. It was helpful in reducing stroke, and it was helpful in reducing non-fatal myocardial infarction. And then we said physical inactivity is a driver for metabolic syndrome. So it is very important that we increase our physical activity, especially whenever we have a sedentary lifestyle. And we know that sitting is the new smoking. So it is very important that we do not sit for prolonged periods and we do physical activity as needed, at least for 150 minutes in a week, as advocated by the American Heart Association. And then we also do have political will to reduce non-communicable diseases and metabolic syndrome in the country. So the government of India, through its various ministries, is running various initiatives in this direction. Like the FSSAI has been implementing the Eat Right India movement initiative. Then the Ministry of Youth Affairs and Sports is running the Fit India movement, and various yoga programs are being conducted by the Ministry of Ayush. So under the Eat India Right movement, the government asks us to reduce fat, reduce salt, and reduce sugar in our diet. Similarly, we all know we celebrated the International Year of Millets in 2023. So basically, the government is also trying to few movement where cycling has been made a Jan Bhagidari movement is also a way to increase or to promote physical activity, especially among youngsters and adolescents. So what we need to do for multimorbidity, how we can manage uh, patients who are having multimorbidity and how we can prevent them. So basically what we need today is our generalists, that is uh, specialists or doctors who can take care of a person as a whole and not just treat single diseases. That does not mean that we do not need specialists. Specialists are well needed for acute care and for episodic care, but we do need generalists, that is family medicine experts, for follow-up care or day-to-day care. And we need to shift away from single disease-centered care to a person-centered care. And for all this, we need wider multimorbidity-based data rather than disease-specific data. We all know that the randomized control trials, they try to exclude patients with multiple diseases. But this should not happen, and we should have, or we should generate data where we have multimorbidity based data. And then we also need multimorbidity guidelines like the one by National Institute for Health and Care Excellence. And as you can see, these guidelines were released way back in 2016. So UK is very well ahead in uh, managing patients with multimorbidity, and these guidelines tell us as to how we can clinically assess a patient with multimorbidity and how we can manage these patients with multimorbidity. So what we do not yet know, we don't, as we said, that there are variable definitions of metabolic syndrome, there are variable definitions of multimorbidity. So we need standardized definitions of multimorbidity and metabolic syndrome. Then, as far as a low middle income country data is concerned, we do not have much data on prevalence and disease patterns and disease pattern specific data from low middle income countries. So we need to generate data from low middle income countries. Also, we do not know, apart from the cardiometabolic and kidney cluster, we do not know much about the other clusters which are commonly seen. So we need more data on other clusters which are seen in multimorbidity and how to detect and manage them. And as we said, there is some genetic predisposition. There are certain environmental triggers which predisposes a patient to metabolic syndrome. So we need to identify these genetic predispositions and environmental trigger factors. So to summarize, it's not that multimorbidity is common in high income countries. Multimorbidity is common in low middle income countries. And to tackle multimorbidity, we need a person specific health system rather than a disease or episode focused health system. So we need to shift away from episodic care towards a longitudinal, integrated, and personal centered care. And metabolic syndrome is a gateway to multimorbidity because it predisposes an individual to various chronic conditions. So can also be called as a perfect orchestrator of multimorbidity or a perfect storm creator. And then to tackle metabolic syndrome and multimorbidity, we need aggressive lifestyle interventions like diet and exercise so that we can prevent and at times reverse metabolic syndrome. So basically, I want you to start with one simple change. Search for multimorbidity in patients who are attending your outpatient departments, or for that matter, even your inpatient departments. So when you see a patient with diabetes, screen for hypertension, screen for OSA, screen for TB, screen for depression, and screen for other cardiovascular risk factors. When you see a patient with hypertension, look for metabolic syndrome components. When you see a patient who is obese, assess for the entire multimorbidity cluster, and that this is how you can identify patients with multimorbidity, because the earlier you identify, it is better. The earlier you treat, the earlier you can reverse the metabolic syndrome or the multimorbidity. And whenever you have a patient with multimorbidity, try to use integrated care principles. Try to see the patient as a whole, try to reduce the pill burden, try to look for drug-drug interactions, then try to treat only those diseases which are of a significant concern to the patient. Do not try to treat laboratory values, try to treat only symptoms which are of concern to the patient. And then use digital tools if available and if possible. Like India is leading its way with ABDM. So we have almost 73 health accounts which are registered under ABHA. So we can make use of ABDM, e-Sanjeevani, that is telemedicine, so that we reduce the hospital visits and hospital expenditure for these patients with multimorbidity. And we should always make it a point to involve the patient as a partner in their care plan. So thank you very much.
Thank you so much, sir, for this informative presentation. As a token of appreciation, I request Dr. Krupal Joshi to kindly present the memento to Dr. Kunal Devkar. Thank you, sir. Now I would invite our third speaker, Dr. Vijayata Jagtap ma'am, Associate Professor in the Department of Obstetrics and Gynecology, AIIMS Rajkot. Ma'am has pursued MBBS, MS and DNB in Obstetric and Gynecology, along with fellowships in minimal access surgery and assisted reproductive techniques. She has been felicitated at the SOGS Annual Conference in 2023 and 24 for her academic contributions. Ma'am has authored 16 original research papers and also a book chapter on chronic hypertension in pregnancy in Fox's postgraduate obstetric textbook. Today, Ma'am will deliver her deliberation on non-communicable diseases in the womb and their effect on the mother and child. Over to you, ma'am.
So thank you for the introduction. Good afternoon, everyone. I will be talking about the non-communicable diseases in womb and how they affect the critical pair of the mother and child. So we all know the famous saying which says, as you sow, so shall you reap. So the fetus is actually a very vulnerable seed which we are sowing, and the maternal environment around the seed which will affect our future. So I will begin with the concept of obstetric transition. We have seen a lot of shift in the recent causes of maternal morbidity and mortality around the world. Initially, we were struggling with the direct obstetric causes like hemorrhage, sepsis, and unsafe abortions. And now the shift is towards the indirect causes of mortality. MMR is reducing. It has dropped by 40% because of the combined efforts of the healthcare system. And we tend to attain a target of below 70 by the year 2030. But the non-direct causes, importantly, the non-communicable diseases, which are affecting the mother and the neonatal health, are increasing, and they are now contributors towards 40% of the mortality rates, even in the low and middle income countries. So again, with the increasing maternal age and the aging population and growing utilization of the healthcare facilities, which is actually a positive aspect, but it poses a lot of challenges and we have to prepare ourselves for the further tsunami of NCDs. These are some of the common NCDs that are affecting in pregnancy. I will briefly touch upon few of them. And I will also talk about two window frames or the windows of opportunity, that is the preconceptional phase and an extended postpartum phase, so that we can protect the mother and child against the NCDs. So regarding gestational diabetes mellitus, it is a glucose intolerance or hyperglycemia which is first time recognized in pregnancy. And more commonly, it is seen around 24 to 28 weeks of gestation. The causes are basically the human placental lactogen that leads to beta cell dysfunction and maternal obesity, which leads to hepatic gluconeogenesis and causes insulin resistance. It complicates around 7 to 10% of the pregnancies. These are the various risk factors. Here, ethnicity, body weight problems, decreased physical activity are very important. Past history of gestational diabetes is also very important because it is a recurrent condition with each pregnancy. So the newborn birth weight is a very important marker here. 4 kg is the cutoff for macrosomia in India, and in the Western countries, it is around 4.5 kg. And a history of polycystic ovarian syndrome is an important risk factor. So previously, whatever screening we were doing with respect to GDM was based on these high risk conditions. But now the government of India has also recommended universal screening for all antenatal mothers. Why this is important is the ones who are having gestational diabetes, they also tend to develop hypertensive disorders of pregnancy because of the placental syndrome, leading to preeclampsia and increased risk of cesarean section. Long-term complications include the presence of causing diabetes mellitus, metabolic syndrome, cardiovascular disorder. Fetal complications which are exclusive here are macrosomia and shoulder dystocia, which again lead to a lot of maternal morbidity and neonatal morbidity and mortality. Also, the newborn who is born to the diabetic mother requires a lot of vigilant monitoring in the NICU for the first 48 hours of life. These are various diagnostic criteria for GDM in pregnancy. Most commonly worldwide, IADPSG criteria with the 75 gram of oral glucose tolerance test is being followed, where 2 abnormal values out of the 3 values will give you the diagnosis of GDM. But as per SOP of GOI and gestation, which came in 24, we are now doing the universal screening, like I told you, for all pregnant women. It can be done twice, once during the first trimester or the booking visit, and second at the time of 24 to 28 weeks, because this is the point where you can catch the maximum cases. The advantage of doing DIPSI, which is the test conducted in India, is that you require just a single step value, a 2-hour value after 75 grams of oral glucose, and it is irrespective of the fasting status. So you need not call the mothers in a fasting status and take 3 samples. It is just a single step procedure. Cutoff values are 140 to 199 for gestational diabetes mellitus, and if it is more than 200 milligrams per deciliter, then it is a pre-gestational diabetes or an over-diabetes. Management of GDM during pregnancy is also very tricky. It starts with, of course, the medical nutritional therapy. According to weight, we can assess what is the caloric requirement. We can divide the diet accordingly. Metformin can be used up to 2 grams per day, and insulin remains the drug of choice. Intrapartum glycemic targets are very important because GDM is known to cause intrauterine stillbirths, because probably due to the cardiac defects in the baby and causing arrhythmias to the baby. Hence, the glucose levels need to be checked in active labor every 1 to 2 hourly and urinary ketones every 4 hourly. And insulin can be started as per the sliding scale, which I have shown in the slide. There are certain self-care interventions that have been given by WHO for GDM. Most important ones are the keeping a log and tracking the pattern of the blood glucose levels. Now, even with glucometer, the blood glucose levels can be measured. So we can teach the patients how they can keep a good monitoring of their sugar values. Rest are the lifestyle modifications and blood pressure control and management. What is important is, again, a fetal movement monitoring, because like I told you, it is known to cause stillbirths and intrauterine fetal deaths. Giving them a proper birthing plan and terminating them on time is very important, and providing them an emergency plan and a contact information. Now I'll move on to chronic hypertension in pregnancy. So it is a blood pressure of more than equal to 140 by 90 mmHg, and it is diagnosed either prior to 20 weeks of gestation, or the mother is already on the medications, or the hypertension which was developed during the pregnancy, but it is persistent beyond 12 weeks of delivery. Here again, the incidence rates are up to 10%, and the risk factors are pretty much similar to the ones we had seen in the previous condition. Now, why this is important is, again, diagnosis and severity is often masked in pregnancy, because of the progesterone effect, tends to cause fall in the peripheral vascular resistance. Hence, we need to pick these cases up very briefly. 25 to 50% of cases would end up having a superimposed preeclampsia, severe hypertension, and hypertensive crisis. Risk of premature placental separation, abruption, intravascular coagulation abnormalities are very common, and the patient can land up in an acute renal failure. Same goes with the perinatal outcomes. They are up to 35 to 40% of the cases will have a compromised outcome in the form of preterm births and increased NICU admission, because in most of the cases of hypertension, you need to deliver the patients often prematurely, because the blood pressure is not under control, or there is risk of convulsion, or there is presence of convulsion. So any antenatal mother who comes with a systolic blood pressure of greater than equal to 135 mmHg and a diastolic blood pressure of greater than 85 mmHg will require further evaluation. A tight control of blood pressure is required, and severe hypertension beyond 160 and 110 is known to cause hypertensive encephalopathy, stroke, left ventricular failure, myocardial infarction, pulmonary edema, and acute renal failure and aortic dissection, very rare. What are the challenges? Challenges are there with respect to hypertension, because there is complexity in the management of this condition. Because most of the medications that are used for hypertension will not be useful in pregnancy. A cautious use of diuretics is important. The ARBs and ACE inhibitors are a contraindication in pregnancy, because they are known to cause anomalies and neonatal deaths. And even beta blockers like atenolol have a risk of IUGR. Also, it requires a specialized intensive care, and persistent postpartum complications are very important to prevent. We need to prevent long-term complications, because most of the cases might even present in the postpartum phase. Patient might not be hypertensive initially, but she might develop hypertension in the postpartum phase. The financial burden is very huge. There have been a lot of studies which have shown that for any country, the management of mother will have an extra weightage of $1 billion and another $1 billion for the management of the infants above the routine pregnancies. I will just briefly talk about the heart diseases in pregnancy, because it in itself is a very huge topic. But what we need to know is it complicates around 2 to 3% of the pregnancies. Now, again, not only in the developed countries, but also in the developing countries, there is an increasing population of pregnant women who have a surgically corrected congenital abnormality, which might derange or which might complicate it with the effect of pregnancy. And rheumatic heart disease is still a public health problem for developing countries. 40% of the women who have cardiac lesions are either mildly symptomatic or they are undiagnosed prior to pregnancy. Hence, we have a very good chunk of population which needs to be screened here. What pointers which we can use towards the cardiac diseases is any progressive dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, any form of diastolic murmur, arrhythmias will require further evaluation and diagnosis. Then there have been studies which have shown that there is inheritance pattern of heart diseases as well, especially with respect to Marfan syndrome. It is an autosomal dominant disorder. So if the father and mother are affected, there are 50% chances that the child would be affected. Around 18%, 15 to 18% risk is there with respect to aortic stenosis, and even the septal defects are inheritable if the father or the mother are affected with the same disorders. This is a modified WHO risk classification for pregnancy, which classifies the heart diseases into class 1 to class 4. Now, why this is important is because it is associated with the mortality rates. If you look at class 1, class 2, the mortality rates would be around roughly 5%. The classes 2 to 3 and 3 could be around 25 to 50%. But what we are concerned about is the class 4. Here, because the mortality rates could be as high as 75% in pregnancy. Hence, pregnancy is contraindicated in these conditions. Some of these conditions are a left ventricular ejection fraction of less than 30%, a severe pulmonary hypertension, any uncorrected cyanotic congenital heart disease, severe aortic root dilatation, aortic stenosis, mitral stenosis, and uncorrected aortic coarctations. So this again is very important to prevent the mortalities in mother. Then I'll just talk about the thyroid disorders. Hypothyroidism, why we are concerned is because the mother can develop postpartum hemorrhage, can develop a placental abruption, and can develop hypertension in pregnancy. Regarding fetus is at the risk of neurodevelopmental delay if the thyroid levels are not under control, can cause cretinism, deafness, stunted growth, even peripartum hypoxia and neonatal mortality. So this is a flowchart how we manage hypothyroidism in pregnancy. Even the subclinical hypothyroidism needs to be managed medically here. Prior to conception, it is recommended that if the TSH levels are even between 2.5 to 4, we need to correct them with the low doses of levothyroxine. Between 4 to 10, again, treatment is required, and definitely treatment with levothyroxine is important once the TSH levels are above 10 milli-international units per ml. Regarding hyperthyroidism, unique complication factors are the mother might go into a thyroid storm, or there could be development of the congestive heart failure. And for the fetal perspective, the newborn child or the neonate can develop hyperthyroidism because the antithyroid antibodies tend to cross the placenta and will lead to hyperthyroidism and Graves' disease in the newborn child. Other complications are pretty much similar, which we have discussed in previous conditions also. Regarding the malignancies, I will just talk about CA cervix or the cancer cervix briefly, because it is the most common gynecological malignancy which is diagnosed in pregnancy. 30 to 40% of these cases affect the reproductive age group. Most of the mothers who are young, they might not have sought any healthcare facility before pregnancy. So this is a unique opportunity that they visit a gynecologist, and it has been seen that 14 to 47% of the cases, around 14% of the patients would be diagnosed in the early stage, and 47 in the stage of 1B and 1B2. Unique challenges are that there is a dual imperative here, because we need to safeguard both the mother and the fetus. So the treatment is a challenging part. Screening is not recommended in pregnancy because the cytology is altered because of hormonal effect. If at all diagnosis is to be done, it can be done with a colposcopy guided biopsy, but an endocervical curettage is contraindicated. Treatment would purely depend upon the patient's desire, whether she wishes to terminate the pregnancy or she wants to continue the pregnancy. Surgical management is for advanced stages is often recommended in very early weeks of pregnancies, because the fetal outcome is anyways compromised here. And beyond 22 weeks, you can give a neoadjuvant chemotherapy. The window of opportunity here is with respect to the HPV vaccination. It is not recommended in pregnancy, but definitely we can give it in the postpartum phase. Lactation is not a contraindication for same. Most of the patients are very young. So if they are less than 26 years, it is recommended that if they are not vaccinated, we can give them vaccines. And between the age group of 27 to 45 years, we can take a call based upon the condition. Regarding the mental health disorders in pregnancy, traditionally we have always seen three conditions like postpartum blues, postpartum depression, and postpartum psychosis, which have now been little more divided into the following four conditions which I have mentioned in the slide. Incidence rate are increasing. They are becoming 15 to 20%. Risk factors are past history, family history, pre-existing disorders, substance abuse, unmet expectations of pregnant and pressure because of the pregnancy, and any adverse obstetric outcome is known to trigger these conditions. Treatment is to be continued in the same way, but the causes of concern are the dose adjustment of the medication, because if they are not adequate enough, they will lead to relapse of the case or uncontrolled situation, and the withdrawal illness is seen even in the newborn child. So the newborn child also requires monitoring in the NICU. Antenatal depression is also on the rise globally. The percentages vary as per the countries, 15 to 65%, but a pooled majority will come around 17%. Schizophrenia has a very high attrition rate in pregnancy. And if you look into the confidential inquiry reports of most of the countries into maternal deaths, here I have quoted the percentage only from UK, but it is all pretty much similar with respect to all the countries. Even in the late causes of maternal mortality, which is self-harm or suicide, comes up to around 39%. Now I will talk about the two windows of opportunity which I had mentioned initially. One is the preconceptional period. The definitions are variable. It could be from 3 months prior to conception, or it could be up to years. It will depend upon the biological, whether we are considering the biological definition, the individual definition, or the clinical definition. But with respect to public health, it could be from months to years. It could be the entire adolescent phase. Hence, we need to focus on the preconceptional health, and the couple here should be fit to be pregnant. Even the paternal health would affect the child. Still, we are struggling with common problems like early marriages, early pregnancies, and 40% of the pregnancies still are unplanned. Hence, we again need to focus on this age group so that we can work upon on mitigating the complications. Risk assessment are pretty much the same. We know that even lean PCOD is a very common problem with developing countries. Underweight, undernutrition is also a problem, not just obesity. And even paternal factors like age, nutrition, and addictions are going to affect the outcomes. Complications unique to this are subfertility and recurrent pregnancy losses. Rest are the ones which we have discussed. Other important thing is congenital anomalies like neural tube defects and the cardiac defects. What is the scope of intervention here to prevent NCDs? One is, of course, with respect to lifestyle modification, BMI calculation, weight management, blood pressure measurements, endocrinal profile, at least thyroid profile, and HbA1c for diabetes is very important. Why I have mentioned 6.5 is again that pregnancy is contraindicated if the HbA1c levels are beyond 10, because they tend to cause congenital anomalies which are very specific like cardiac anomalies or CNS abnormalities. Then screening for inherited blood disorders can also be done, nutritional checklist and food fortification. There are many countries who are actually running a national free preconceptional health examination project. Even our neighbor China is running that project so that they can identify the high-risk population and optimize the medical condition just prior to the women going into pregnancy. Nutrition-related deficiency correction is definitely recommended prior to pregnancy with a focus on iron, iodine, vitamin D, and calcium. Gram of folic acid as a supplement to the expecting mother. Then extended postpartum care and the non-communicable diseases. Again, here we have seen that up to 40% of the mothers will never attend a postpartum appointment with the obstetrician because she's so involved with her other responsibilities and taking care of the child that if she feels that she is asymptomatic, she will not return. Hence, we can again have an opportunity to or basically at the community level. Why this is again important is most of the disorders that we have seen, be it diabetes or hypertension or any other condition, they need to be rescreened at 6 weeks when the puerperium is over, then again a screening at 3 months, and then follow up at 1 year, and timely again follow. It could be up to every 3 years because all these mothers are going to develop non-communicable diseases in future. If I talk about hypertension and diabetes only, it is 7-fold increased risk within the first 10 years of childbirth. Hence, these mothers need to be traced and monitored. Again, if they land up in having continuation of the hypertension, then cardioprotective and renoprotective antihypertensives could be started. Annual screening of end organ damage can be done. For GDM, effect. So it is to be promoted at least for the first year of childbirth, and the contraceptive counseling has its own importance. Little bit about the epigenetic programming, because whatever the developmental environment is there around the fetus in utero and the other environmental drug related aging and diet related problems, these mechanisms they alter the DNA methylation, cause histone modification, and lead to health problems in future like cancer, autoimmune diseases, mental disorders, and diabetes. So the battle for NCD is beginning right away in the uterus itself, and so we can start the prevention there and there. For all the conditions which I have mentioned in the slide, these babies tend to develop obesity, metabolic syndrome, cardiovascular diseases, low birth weight, developmental illnesses, and mental illnesses, either in the childhood or the adolescent phase or at the adulthood. Little bit about the preterm births. These babies are born too soon. We have a global burden of 15 million babies worldwide every year, and 1 million of them die due to complications of prematurity. It also contributes to 35% of under 5 mortality globally. Now, why we are concerned is the long-term effects. Long-term effects could be in the form of neurological and developmental problems because of cerebral palsy, autism, or because of ADHD. Also, prolonged NICU stay. Also, prolonged NICU stay could lead to sensory problems like vision problems and hearing losses, bronchopulmonary dysplasia, and later they can develop hypertension, cardiac diseases, and metabolic disorders. There is a famous Barker's hypothesis given by the physician and Barker in the 90s, which says that low birth weight babies, premature babies, and the intrauterine growth restricted babies will have a causal relationship with the origin of non-insulin dependent diabetes, hypertension, and the coronary heart disease. So this is basically the developmental origin of the adult diseases in the womb and childhood. There is also a thrifty phenotype hypothesis, which says that a poor maternal nutrition could lead to lower birth weight in the baby, and the baby is at the risk of developing adult onset type 2 diabetes. Now, diabetes either can cause this growth restriction and preterm babies, or it could cause large for gestational age babies. So even if the baby is large for gestation, or as we call it as macrosomia, it will have a tendency to develop metabolic syndrome and obesity and type 2 DM in future, which is called as the transgenerational programming. Interestingly, there has been enough evidence which says that female offsprings who are born to mothers who are having hyperinsulinemia or insulin resistance, they themselves are vulnerable to develop PCOD or the polycystic ovarian syndrome and GDM when they themselves will become pregnant in future. So where do we go from here? What is the road ahead? Either we can do the interventions at 3 levels. One is at the universal level, and then we can target the population and then intensify our measures. So we saw a significant overlap between the NCDs and the maternal and child health service aspects. Integrated action and convergence along these domains will definitely enable the women and child to have a very long, healthy life. We can assess the current knowledge, take actionable steps, and do the information gap analysis. Major barriers to delivering this integrated care is the healthcare workers that are there. They often lack adequate training with respect to NCD and MNC overlapping and the resource limitation. Another important thing is shortage of the specialized workforce and the targeted approach towards the marginalized communities and the treatment defaulters. So at community level, what we can do is disease prevention, health promotion, health literacy, and healthcare seeking behavior we can promote. At the facility level, it requires a multidisciplinary approach to have best clinical outcomes and a robust referral system. And overall, for the health system, we can consider the logistics, diagnostics, supply of the medicines and technologies, program management, monitoring, and policy and research related aspects. So these are some of the references for my slides. And that brings me towards the end of my session. Thank you for patient listening. Small changes will definitely bring about big impact, and health will begin in the womb. Thank you. I am greatly thankful to the Department of CFM at AIIMS Rajkot for providing this opportunity. Thank you so much.
Thank you, ma'am, for this wonderful deliberation. As a token of appreciation, I request Dr. Anjali Modi to kindly present the memento to Dr. Vijeta Jagtap, ma'am. Now I invite my colleague Dr. Avinash Vyas to introduce our next speaker.
Thank you, Dr. Krishna Jasani. Now I will cordially invite our next orator, Dr. Pradeep Burde, Additional Professor in Department of Physiology, AIIMS Rajkot. Sir's recent work includes research on body composition and metabolic health of police personnel in Rajkot, as well as AI-based anemia detection. He has contributed significantly to the clinical validation and development of several indigenous medical devices, holds a patent in ultrasound technology, and has received prestigious awards, including the Best Paper Award at FIPS 2019 and ICON BAP 2023. His current interests lie in body composition and autonomic function. Today, Sir will deliver a session on long-term results from daily changes by lifestyle modifications. Over to you, sir.
Thank you for the warm introduction. Good afternoon, all, and my earlier colleagues have made my job easier, considering they set the right environment to discuss about long-term results of daily lifestyle modification and what are the evidence-based health benefits that we can have. So my aim is to understand what is general evidence by one of few studies that indicate that long-term benefits of the lifestyle modification, and we'll discuss few of our experiences at AIIMS Rajkot as a part of this discussion. So yes, lifestyle modification impact longevity, health span, and chronic disease prevention that we have discussed in the previous presentations, and a number of evidences for that. And small and consistent daily changes contribute to large health benefits over time, because lifestyle modification is not just about the diet and exercise, but it goes much more beyond that in terms of behavioral modification, and that is now being focused in terms of making sustained changes and maintaining the lifestyle modification. So I should start with this, that the concept of thin fat Indian, and the image is of the two famous scientists. One is Indian and one is the international, and apparently they have similar BMI and they look different. The Indian counterpart looks little thin as compared to the Caucasian counterpart. And if you see their body composition is same, but what you see differently is their body fat. And this is not new concept. It is much older concept, but still it has a relevance in terms of the tendency of Southeast Asian population to have centripetal body fat, and that is the challenge to sustain the effect of lifestyle modification. So we are fighting against our tendency to have centripetal body fat. So these are the few, key lifestyle areas where we need to work upon, apart from the traditional physical activity and dietary intervention. But other three things are also important pillars of lifestyle modification, in which, according to me, considering the current level of stress, work-related stress that we have, or any other stress that our population is going through, and because of that becomes the behavioral habits, and that impact the sleep duration and quality of sleep, though very not very recognized kind of risk factor for the various diseases related to lifestyle. So here these three things, apart from the physical activity and dietary improvements, are very important to consider. But today is not the day to discuss in detail about them. We'll see how they impact our health. So this is one of the famous study of DPP-4, diabetes prevention program, of more than 3,200 overweight and obese individuals were followed up for 4 years. And if you see their cumulative incidence of diabetes in them, those with the lifestyle, those who are on the metformin and those who are on the placebo, no change. So you can see the benefits after the 4 years also sustained in the people or in the patients who have followed the lifestyle modification intervention in their journey. So the lifestyle intervention were designed in this study to induce 7% reduction in initial weight and increase physical activity of 150 minutes per week, and that reduces risk of developing type 2 diabetes to more than 50% as compared to placebo. So that is the importance. That means if you do a simple change of 7% reduction in initial weight and follow physical activity of 150 per minute per week, 150 minutes per week, so the risk is reduced more than 50%. So that indicate that lifestyle modification have effect on long-term weight control and NCD like diabetes being decreased and associated metabolic disorders that we have discussed in previous session. Now this tells the efficacy of lifestyle modification on long-term weight control. Now the point I highlight here from the previous slide, apart from development of risk of diabetes, if you see, that is the challenge in most of us who follow lifestyle plan. Over a period of time, you tend to not to get as much as benefit. If you see the scale, if you see the measurement, that the initial reduction in weight in the half, like after 6 months to 1 year, slowly you tend to gain weight. That means lifestyle modification as a measure, we feel that it is not that effective. But still, if you see in these three groups, that is one placebo without lifestyle intervention, one with medicine, that is metformin, and one with lifestyle intervention, there is a consistent decrease in the weight, and even the weight has increased at the end of 4 years, still it is much lower as compared to the initial weight, and it maintained at that level. That means one of the key area of weight control we talk about is very effective in terms of long-term effect of the lifestyle modification, and it works. Though there is change. Now we'll discuss in detail. It is when we say the weight, what we all talk about, whether it is the muscle, whether it is body fat, and when it is body fat, which body fat we are asking or we are talking about, whether it is a subcutaneous fat or whether it is a fat reduced or the fat stored in the around the viscera, what we call as a centripetal fat. So that discussion is very important when we talk about the effect of lifestyle modification on various NCDs and the risk factor for various NCDs. So in terms of this, what are the contributors to the weight regain? I mean, we discussed that we started some lifestyle modification program and we followed it religiously for say 3 months, maybe sometimes 6 months, or maybe for 1 year. But what after that? Weight has regained. So what are the major contributors to this weight gain? According to one study, the compensatory metabolic responses to weight loss. So our body is very, nature is interesting that when we try to follow the weight loss measures, we first reduce the calorie intake, we try to avoid the high calorie foods, and then various other activities related to that, but that create an environment of starvation, and that signal is generated, and that causes compensatory metabolic responses to the weight loss. That is one of the thing that can cause weight gain. Reduction in resting energy expenditure, that is another thing, that various type of diet and the patterns of diet have evolved, and few diet focus on the intermittent fasting or the interval fasting. So such kind of diets also can cause and trigger the metabolic responses. So one of the important output of the metabolic response is reduced resting energy expenditure, what we call in terms of basal metabolic rate. So that again become a contributor for weight regain. Then reduction in the hormones that modulates our satiety and hunger phenomenon. So reduction in leptin and increase in ghrelin and related hormones. Again, they are secreted or increased as a response to the starvation or the what we say diet. I mean, decrease in the quantity of diet or the type of food that we consume, and that again contribute to the weight gain. Then this fourth point, point of discussion here, that we are confronted daily by an environment that explicitly encourages them to consume large quantities of food high in fat and sugar. So if you go and see your dining table, or if you go to the canteen and see the menu of canteen, or suppose today we have CME and we are sitting in a hall and refreshment were arranged, what was the part of refreshment? Mostly such kind of food. But we are exception here at AIIMS Rajkot. What we have arranged, or our organizers are arranged, I am very happy to see that they have arranged a dry fruit mix with seeds, and that is really healthy. But we like to see many more refreshment as a part of the such functions, and acceptance from the audience also to have such thing. So that we really appreciate. So this thing, that the advertisement we see around us, the type of food that can be considered as a party food, or the whenever you call somebody at your home, or when you do something that when you are really happy and you want to eat, what we'll eat, that aaj to mera cheat day hai, so I will have something high in fat and high in sugar. So, and it is not just our own fault, because the kind of environment around us is created in a manner that we, lose emotionally to the stimuli, and we tend to have that kind of food, and that is major contributor for weight regain, because finally we are not robots. Like we are programmed that you are on a weight loss strategy, and now you have to avoid that. But we are humans, we are emotional, and then at a point of weak moment of emotion, you tend to fall for such environment. So imagine if such environment is not there, then definitely that would have contributed to the weight maintenance rather than weight regain. Then, okay, we have controlled the environment, we have taken care of various things, but yes, few things are not in our hand, and that is the genetic influence. These are few examples, that is fat mass and obesity gene, and then vitamin D receptor gene, and many more examples are there, which have indirect impact in spite of the strong dietary regimens or the exercise regimens that have impact on our weight loss regimen. So yes, genetically there is challenge, and it is individual, as one of the speaker was talking about. It should be individualized approach. So yes, we have to understand our own challenges if you are not able to maintain the weight loss. And again, we have the challenge of weight loss regain or the weight gain. Then yes, there may be answer in our genetic makeup. But with the certain limitation, once we know that, then we can work upon that. So this is a comparison between instant weight loss, I mean short-term weight loss, and the maintenance of weight loss. So the way it is different, it is very important to discuss. This is one of the study in the past. So, but it is still valid in terms of, if you see the weight loss goal of an individual on the short-term basis, the goal of treatment is to lose large amount of weight after a prolonged period of weight gain. But in terms of maintenance, goal of treatment is to lose small amount of weight as small increase in weight occur, that we have to take it. Then in terms of short-term weight loss, dieters' principal strategy is to avoid eating all of the food that has caused the weight problem. What will be the strategy for maintenance weight loss? Dieters' principal task is to learn to eat troublesome food in a controlled fashion, that is mastery over, I mean, having own self-control, and eat a new food low in fat and calories. That means having choices of better food that will help in maintenance of weight loss. Then in case of short-term weight loss, treatment is time limited, usually 15 to 25 weeks in terms of packages that are advised by various weight loss companies or the programs or the institution that run that. But here, maintenance of weight loss require an ongoing and lifelong policy. Diet but what about maintenance of weight loss? Dieters receives little or no support from professionals or family members. That means he or she month for 2 years or 3 years every time for your weight loss program. Exceptions will be there, but I'm talking about of majority. So in terms of that, you have to be motivated on your own, and that again challenged by your environment. So weight loss is highly reinforcing in terms of short-term weight loss. It is very noticeable and pleasing to dieters and their families. And in terms of maintenance of weight loss is not reinforcing. Dieters forget about their accomplishment, as do their family members. So there is no encouragement in terms of maintenance of weight loss. Dieters do not have exercise to lose the weight in terms of if they just follow the short-term weight loss by doing the diet control. But yes, in terms of long-term maintenance of weight loss, exercise appears to be a critical to maintain the weight loss. So from our center data, like we conducted one study in police population where we measured the body fat percentage as a part of body composition analysis. As I was talking about, when we say weight, it is and height and the BMI, we are understanding less about the body proportion of a person. So we have to go in detail to understand what kind of body composition person is having, and one of the way to measure body composition is measuring percentage of body fat. So we did it in our lab with the help of anthropometry, and we calculated the percentage of body fat, and we could see that the percentage of body fat in the police population, we did this study in police population, was quite higher as compared to the normal population. And their this body composition or the body fat percentage critically related to the one of the parameter of autonomic function that we measured with the help of heart rate variability. And that in short told us about they are having decreased parasympathetic, that is the system that calm you down and increase sympathetic activity. That is system activated or indicates indirectly you are in stress, and we know the stress is related to obesity. So they are related in terms of the percentage of body fat and the RMSSD, I mean one of the parameter for parasympathetic function. So as the body fat percentage increases in us, it tells us that the level of parasympathetic activity, which is a good autonomic nervous system in terms of calming us down and decreasing our stress, its activity is decreased. So that is not a good sign. Then another way we try to measure, because doing anthropometry is many times is a cumbersome technique and that require a lot of patience. So we have now devices, and one of such device is based on the bioelectrical impedance analysis, and we measure body composition using this in almost 200 male subjects, and 100 were police and 100 were the age matched non-police population. and we measured psychological parameter in them. We also measured the autonomic parameter in them, and what we could decipher in terms of the body composition, beginning with the weight. Average weight was higher in police population. The BMI was higher, and if you see the cutoff for the Southeast Asian population, it is 23 for being overweight. So it was 25 in them. Then waist hip ratio was definitely higher, indicating centripetal obesity. If you talk about body fat percentage, it was higher. Then visceral fat area, one of the parameters measured by the body composition device, it was the more than the 100, and it was indicating the abnormal or the propensity to have the metabolic disorder. Then whole body phase angle, one of the another measure was poorer in the police population as compared to the normal population. So waist hip ratio was definitely higher. So if you see the importance of body composition in understanding the differentials of the fat distribution within the body, type of muscle mass that we have in the body, and its composition, that tells us that how can we help our person who want to lose the weight and have need to reduce the risk for the NCDs. So further, if you see the changes in the cardiovascular parameter was different, significantly different in the police population as compared to the healthy population. They were under stress as compared to the normal population. Now, coming further to the case study on another kind of thing that we do in our lab. So in that, this is a case of a 25-year-old male, a student, height of 180 centimeter and weight of 88.3 kilogram. BMI was 27, so definitely in the overweight or obese range. And if you see the initial score of in-body, one of the composite score that our equipment gives, that is 49. And if you see the visceral fat area, anything above 100 is considered abnormal for that age. So his area, visceral fat area, was 179. So if you see the out of the body fat the person was having, most of it was around the viscera. And if you see the lower part of the diagram, that tells us body composition history. So the first measurement taken by the person was in the May 25, and if you see the 8 was 88.3. Now in the current measurement is in the last measurement was taken in 16 September 2025. So from 88 the weight has been reduced to 74. Now within that, if you see, interestingly, the SMM stand for skeletal muscle mass and PVF stand for percentage body fat. So if you see, there is an increase in muscle mass and there is a decrease in percentage body fat. And what you see, muscle mass increase is a very, you need great effort to increase your muscle mass. In fact, you need to maintain your muscle mass first. So if you see in this patient history from May to June to July, then August. So if you see 29.23, 29.6, and initially there is reduction after 2 months in muscle mass. And there was exams and something that was going on when we discussed in detail. So the muscle mass reduced to 27.5. But after that, the person again started exercise with protein supplements in terms of the dietary supplement, not in terms of the bodybuilding supplements, but the muscle mass was increased. So this phase comes in every person who start lifestyle modification program, and there may be some kind of muscle mass loss based on the individual. It is not in every case, but in most of the cases we see this. But what consistently you can see that the body fat percentage was reduced from 39 to 27% at the end of the September, this mid-September, and that began from the early May. Now, this example tells us that the sustained changes and the changes, the person being the student, what changes he did that we advised him was small changes in diet, that is avoiding the food that high in calorie and high in sugar. Then go for the resistance exercise apart from the aerobic exercise that is appropriate for his age and his earlier body build. And then apart from that, important pillars of lifestyle modification, that is stress management, regular sleep cycle, avoiding the the stimulants in terms of not only stimulants or drugs are not always smoking or the alcohol, but simple excess caffeine intake also can have problem on our sleep cycle and the stress activity. So they were advised to them to do that. And one of the important thing is to have a good social connect. We have good social connect on social media, but we have very good less social connect in the people who are actually surrounding us, and that matters to reduce or increase based on what if you have or if you don't have your psychological stress. So that all parameters as the pillars of lifestyle modification has been consistently followed by this person. So far we have reached to 6 months, but still it shows the consistent benefit of lifestyle modification in this subject. So in summary, different lifestyle modification guidelines also tells us that the small changes go long way and help us in maintaining the reducing the risk factor for the NCDs, and one of this is obesity. So what ICMR and some regional national guidelines says that we have to add culturally specific recommendation and use traditional practices. Like in our country, ICMR also says that you have to use our traditional science and then yoga. And if you say yoga, it is not just about yogasana. If you say the real Ashtanga yoga, most of you must be knowing that it starts with the 8 steps, and the first step is yama and niyama. So yama and niyama is nothing but to reduce your own stress in terms of how you behave with yourself and how you behave as a society, in society as a human being. So if you follow that also, that reduce or that will take much of your stress and calm down you as a person. And then come asana, pranayam, pratyahar, dharana, dhyana and samadhi. So out of this, these first 4 steps if you follow, and that will take care of all pillars of what you say the lifestyle medicine that is being practiced in West, and we are following that. Definitely that is good, but still if you follow these 4 steps, they will take care of same thing that has been told. So that's why ICMR is also recommending that to include the culturally apt practices in lifestyle modification to make them a sustained change, because challenge is not the short-term reduction in weight or short-term reduction in risk of NCDs, but challenge is to maintain them and become a lifestyle. So what we call as a yogic lifestyle. So yogic lifestyle is not like having the clothes like a sadhu sannyasi and going in some ashram, but it is the doing your daily course, daily activity, but follow a mindset of a yogi, and that is taught us by yoga. So apart from that, ICH provide comprehensive updated international consensus with detailed nuances on guidance of diet, exercise, weight, stress, and key factor here I really appreciate is pollution exposure, because we really care for it, but it is indirectly killing us. And most importantly, we always talk about outdoor pollution, but if you read in detail science of indoor pollution, it is further dangerous than the outdoor pollution. And most of us who have risk of NCD or at the risk of NCD are mostly indoors and having the problem of or the but today is not the day to discuss in detail, but yes, we have to always think about our environment or what kind of the measures we can take to reduce the indoor pollution and exposure to it. And last but not the important list or not least important was the exposure to digital tools or use digital tool positively for the maintenance of lifestyle modification measures. ADA integrate diabetes specific nutrition guidance, self-management education, and pharmacological adjuncts along with the lifestyle, and WHO and European guidelines also strongly emphasize public health strategies, societal roles, and life course approaches. Now, this life course approaches, it not just limited to adults, but it should begin or it begin in their guidelines, begin from the school age or even before that, as one of my previous colleague was talking about the pregnancy and the theme of today's CME from the OM. So it begins definitely with OM or before planning for OM. I mean, before planning for the birth of the baby, that is preconceptional, what she rightly emphasized. So this life course approaches, we are talking about that, and different guidelines are now talking about that, but it will become really useful when we actually follow it in our regular practice and follow ourselves. Thank you.
Thank you, sir, for the informative session. As a token of appreciation, I request Dr. Bhautik Modi, sir, To felicitate the memento to Dr. Pradeep Burde, sir.
On moving forward, I would like to introduce all with our next speaker, Dr. Anjali Modi, Assistant Professor in the Department of Community and Family Medicine, AIIMS Rajkot. Dr. Anjali Modi holds a PhD degree in the community medicine, has made significant contributions in the field of HIV elimination and maternal and child health. A recipient of multiple prestigious awards including a Star Award at IAPSM 2024 and also 3 consecutive honors in the communicable diseases. Also, she has 44 publications to her credit and actively contributes to the national level workshops. Today, ma'am will talk about the national program for the prevention and control of non-communicable diseases. Over to you, ma'am. First of all, I would like to share my sincere thanks towards our HOD sir, Sharma sir, who has inspired holding this workshop, integrated workshop on non-communicable diseases at AIIMS Rajkot. I would also like to thank my colleagues, Dr. Kripal Joshi sir and Dr. Bhautik Modi, who has, and all the team who has made this possible. And today, I have had a lot of, you can say, I have also learned a lot about the non-communicable diseases from all the respected speakers. And this is an online workshop, so definitely there is no eye contact here or any communication with the listeners. So I will be presenting my slides, which I have pre-prepared for you. And if you have any queries or anything, or I'm going fast, so please let me know in the chat box and I will adjust accordingly. So I'll start the discussion on the national program, the non-communicable diseases. Now, see, this is not SDG in the first slide. This is MDG, the Millennium Development Goals. When the Millennium Development Goals were designed or framed in the year 2000, that means 25 years back from now, at that time, nobody was thinking prominently of the non-communicable diseases. See, all the leaders are there and they discussed the child mortality, the maternal health, combating HIV, AIDS, malaria, and other diseases. So basically, the awareness starts from the healthcare providers. So you see that at the policy level, we're discussing the policy here. At the policy level, the NCDs came later. Then very soon, in 2003, for the first time, World Health Organization used its constitutional authority to establish an international regulatory mechanism for tobacco control. Now, we all know this is historical with a lot of timelines, history, studying and everything. And we got this framework which talks in detail about the effects of tobacco consumption on the health of the people and also the effects of reduction of tobacco consumption on the health of the people. Then came the term smokeless tobacco also, which is considered equally important for low and middle resource countries like India. Now came 2004. By that time, the major risk factors, unhealthy diet and physical activity were recognized at the international level, especially by the World Health Organization, which raised the alarm that 60% of all death and 47% of the global burden of disease were caused by insufficient physical activity and unhealthy diet. Now, Dr. Venkatesh has emphasized in the beginning that there is an epidemiological transition from communicable diseases to non-communicable diseases in the last 3 decades, that is 1990s to 2020 in the global burden of disease. So this was felt and everybody started becoming aware about the importance of diet and physical activity on health. So all these reports, all these mandatas, all these gave rise to the concern, and the result was the World Health Organization Global Strategy, Prevention and Control of Non-Communicable Diseases. Now, if you will see, I hope the slides are clear, you will see in the Venn diagram, on the corner in white is written 4 important causes of non-communicable diseases: the cardiovascular diseases, the chronic respiratory diseases, cancers, and diabetes. So you see that hypertension, diabetes, etc. are holding the major spectrum of the disease now. Now, this priority was raised, focus was on low and middle income countries, and the aim was to integrate prevention and control of NCDs into policies across all government departments. So the main challenge for WHO was to emphasize the low and middle income countries about the importance of non-communicable diseases epidemic. Cardiovascular, as I've already said, the shared risk factors were also identified: tobacco use, unhealthy diet, physical inactivity, and consumption of alcohol. So you see that all these 4 factors are easily preventable or modifiable. Now moving ahead. In 2011, what is this HLM? HLM means high level meeting for non-communicable diseases. The first high level meeting leading to the development of a political declaration of combating and making strategies for NCD was brought forward. For the first time, ministerial conference was done on healthy lifestyles, and the UN political declaration was given. As a result of this, there was a development of WHO Global Action Plan for prevention and control of non-communicable disease. This was a roadmap to take place between 2013 and 20. The main aim was to give policy options to progress on 9 global NCD targets. So now 9 targets were identified with the aim for 25% relative reduction in premature mortality due to non-communicable diseases. The age for this premature mortality was decided to be 30 to 70 years. Now, this is the main heart, or you can say the most important slide to understand for this national program for non-communicable diseases. Now, you see there are small figures, or you can say indicators, which each denote a very important target or a point. Even if you will just look at these small diagrams, you will be able to understand. Pehla kya hai? Drugs, right? So see, those who are already diagnosed. Please mute those who are, please mute themselves.
Mute कर दो आप. हाँ बस अब ठीक आप बोलिए.
Yes, sir. Thank you, sir.
Twinkle.
Okay.
Please continue.
Now you see that this global monitoring framework, what the first icon shows? The drugs, right? So we start from the secondary prevention. The person is already declared as having a non-communicable disease like diabetes or hypertension. So drugs should be available for it so that the further damage can be controlled for this person. उसके बाद एक हार्ट शेप बना हुआ है लाल रंग में, and there are two hands holding the heart. What does this show? This shows that you have to care for your heart. 50% of people should receive preventive therapy. Then there is a person standing, uske piche there is a shadow which is fat version of the thin person. So halt the rise in diabetes and obesity. The salt dispenser, you can see at least 30% reduction should be there in salt intake. Then the wine bottles, 10%. See, even a very small reduction in the use of alcohol can contribute a lot towards the control of non-communicable disease. Then comes the 25% reduction in premature death. You see the sand is coming and it's going and the life is going away, right? So, आप कैसे उसको रोक सकते हो? By all these measures. And then this person is playing or dancing or whatever. So you see that insufficient physical activity. Now, as Burde sir has very rightly shown, and ma'am has also talked about this, the physical activity. What is insufficient physical activity? Recently, I was reading a new article. In it, they were not counting the hours of being active. They were counting how many hours you are sitting continuously. So that means that every hour you must take 5 to 10 minutes break so that this sedentary lifestyle habit is broken. And this small breaks in the lifestyle can make a major contribution towards preventing your risk for NCD. Then comes the cigarette showing a ban. Now remember, for our country, this is the smokeless tobacco, which people usually consume as khani, faki, or like oral tobacco. So then comes the blood pressure cuff, which is the, I must say, सबसे ज़्यादा यही हम ध्यान देते हैं कि भाई NCD means measuring blood pressure. Now what ahead of this? Measuring तो measure तो आपने कर लिया, measure तो हम अपने intern doctor और nursing officer से भी करा सकते हैं blood pressure. But what is ahead of that? So you see that ये जो पहले था सबसे पहले green one, the drugs, the prevention, the obesity reduction, the salt reduction, the alcohol and smoking reduction, and introduction of physical inactivity have to follow the measuring of the blood pressure or the measuring of the diabetes. Now let's move ahead. This came in 2013 and immediately it was followed by the Sustainable Development Goals. Now from the MDG we come to the SDG and we have a definite target: reduce premature mortality by 1/3 by the year 2030, right? So you see, we started in 2000 where there was no focus on the NCDs, and now we have done so much work at the international level. Not we, but all the international leaders. Now in 2014, a commission was erected for preparing a report on childhood obesity. And the report of this commission was very alarming. As a result, immediate attention was brought, and there were the high-level meetings 2 and 3 following this report. And it was said that those children who are gaining the weight in the childhood are going to definitely be victims of non-communicable diseases in their adulthood. So if you inculcate healthy habits in the childhood, definitely these habits will continue in the adulthood. Now, how much physical activity? How much to walk? Should we walk till we are tired? Should we walk till we are sweating, pasina pasina ho jaye, 1 घंटा, 15 मिनट, 5 मिनट? So what is the optimum activity? अभी आपने ध्यान से सुना हो तो it has been discussed by sir that small frequent activity is as important as large intervals of coordinated sessions. Now, this guideline of 2080, it is a global action plan and it gives a detailed guidance framework of policy actions to increase physical activity at all levels. because like food, like other things, physical activity will also have to be acclimatized for each person. हर person के लिए हमें अलग अलग टाइप की एक्टिविटी और टाइम और जो उसको सूट करता है वो उसको देना पड़ेगा, प्लान, राइट? So this is a detailed guideline. Then came in 2019 the universal health coverage for all. Again, see, हमारे पास रोड मैप था 2013 to 20 वाला. Now 2020 is reaching and we have yet not done a commendable progress on preventing and controlling NCDs. So the international leaders, policymakers came for this roadmap 2023 to 2030. This roadmap had highlighted the 9 global targets to everybody. They have said that this is the greatest impact on the prevention and management of the NCDs. Now, this image, whenever you will search for this on the net, it will come as pinprick image. So what we are seeing, a small amount of capillary blood is being taken for testing for blood glucose. Now, in all the countries, including India, it has become as easy as this. Previously, हमें फास्टिंग करना पड़ता था, घर पे सैंपल के लिए बुलाना पड़ता था, जाना पड़ता था, but now we can take the random blood glucose anyway. Even the ASHA worker, the peripheral community health workers have this glucometer with them, जो उनके बैग में हमेशा होता है और हम अपना ग्लूकोज उससे चेक कर सकते हैं, किसी को भी करवा सकते हैं. So you will get at least a primary screening that the person is having diabetes or not, having high blood sugar or glucose or not. Now comes the second step. जिसको भी diagnosis आ रहा है, they should have equitable, comprehensive, affordable and quality. इतने words हैं इसमें. Equitable, everybody should get it. Comprehensive, everything. Health education, counseling, diabetic foot ulcer भी अभी discuss हुआ था. So all these things should include the diabetes care. It should be affordable. अगर आप national guidelines देखेंगे तो उसमें diabetes की drugs freely available हैं, even at the community health officer, that is the health and wellness center level. ठीक है? And quality treatment should be there. Quality means what? At least regular follow-ups once a year or 6 months with a specialist or a person who has an experience of treating the diabetes. Now this was launched in the year 2020. In the same year, along with diabetes, another important disease was brought to attention. It's not like that कि पहले इस पे attention नहीं था, but it was brought back to attention and it was said that cervical cancer is a type of non-communicable disease because there is a vaccine available against it, there's a treatment, and definitely a screening is available against cervical cancer. So if a woman is screened, even 70% of the women are screened in the community at least once in their lifetime. अगर पूरे लाइफ में एक या दो बार भी उनका पैप स्मीयर या टेस्टिंग हो जाता है with the help of the visual inspection जो gynecologist करते हैं, तो these women can be protected from death by cervical cancer. Cervical cancer is a very slowly progressing disease which is amenable to prevention. Now see, this was again in the year nearly 2020. So till now, the importance of exercise, the importance of NCDs, the importance of diabetes was all these were recognized and guidelines were given. Now comes the food. So it's not like that we were not knowing about the importance of food earlier. The thing is, the international researchers, policymakers, doctors, they sat down together and framed a guideline or a policy to guide people from different zones, different horizons, and different countries. Right? So this role of nutrition and healthy diet could be easily addressed. These guidelines were there, and it was expected that the food system transformation of the SDG will take place with this United Nations Food Systems Summit. Now moving ahead,
What is the NCD progress monitor? Very important. See, whenever we are starting doing anything, we always set up some targets, some timelines to be achieved. What this says, the invisible numbers. बहुत सारे लोगों को NCD है और उन्हें पता ही नहीं है. So what to do with them? What to do with these numbers? Then came the Global Alcohol Action Plan. Pace of development and implementation of alcohol policies has been uneven in WHO reasons. Another important point was seen, refugees. आपने कई बार सुना होगा कि किसी को इम्प्रिजन किया गया और हेल्थ रीजंस की वजह से तुरंत ही उसको प्रिजन से हॉस्पिटल में भेज दिया गया, या फिर कोई पर्सन कहीं पे रह गया, बेहोश हो गया और उसने हाथ में एक ब्रेसलेट पहना हुआ है which shows that this person is on diabetic medicine or any other long-term medicine. So you see that on humanitarian grounds, people should not suffer due to lack of the care. So this policy was also made in this meeting. Now, what now? Now this is upcoming 2025. When we started planning this workshop, at that time, this September, 25 September, upcoming meet of United Nations was coming up, and it was expected that it will be focusing on these 6 points. As you can see, diet, alcohol, screen time, both on mobile and computer, and physical inactivity. So the fourth UN high-level meeting focused also on the mental health. See, this is what was proposed, and this is what was held. So again, we have come up with our roadmap, taking into account what all actions have been done and what gains have been made. And then again, the political declaration was given in this fourth high-level meeting that promotion of mental health is directly linked towards the non-communicable disease development in a person. Another important point was equity and integration. So if you send a person from the upper level कि वो जाएगा कैंप में और सबको दवा देके वापस आ जाएगा, that is not going to help. You have to train the people who are living there at the grassroots level. Then only you can achieve the 1/3 decline in premature mortality by 2030. Now coming to some of the extra efforts which were taken by different organizations, for example, addressing non-communicable disease in emergencies, and other guidelines were given. Now coming to the Indian version, our own version of the non-communicable disease. India adapted the National Program for Cancer, Diabetes, CV, Cardiovascular Disease and Stroke in 2010. In this program, the main emphasis was on opportunistic screening. Whoever was coming to your OPD will be screened for the non-communicable diseases, basically at the tertiary and the secondary healthcare level. And this program, then what it was found? It was seen alarming rates, as has already been discussed. NFHS 4, 22% prevalence of the non-communicable diseases. Now, coming to our adaptation of the non-communicable disease program. You see all the icons are here with one increase. Which one is it? Can anybody highlight or write in the chat box? Can you find out which one? Yes, our friends who have joined over here have recognized it. It's the fourth in the top row, the smoke part. See, in India, many women are still using the chulhas, or even if they have gas cylinders, they use wood or other materials for combustion, pani ubalne ke liye, to cook, or these things are also contributing towards the chronic respiratory diseases. Then there are other additions like end-stage renal disease. They are also coming up as a huge contributor to the death from non-communicable diseases. So this was adapted by India, and our program got the name National Program for Non-Communicable Diseases, with the inclusion of these components. And the most important addition was population-based screening. Now, everybody above the age of 30 years was to be screened. So targets were also given. The health workers, the community health officers, the grassroots workers were asked to screen the population for hypertension, diabetes, cancer of the oral cavity, cervix, and breast. So this is known as population-based screening compared to the opportunistic screening, which was launched in 100 districts only as a pilot project. Now this program has been implemented all over India in all districts. So you see, what are our targets? Premature mortality, 25% reduction, right? Alcohol use, 10% reduction. Essential medicines should be there, 80% coverage should be there. Counseling should be there. The due to the color on the screen, blue color, देखिए ये आसाम के तरफ बगल में जो लिखा है 50% coverage of the drugs, ठीक है? Household air pollution reduction, very important. Diabetes increase should be 0%. Raised blood pressure reduction, 25%. Tobacco use, 30% reduction. Salt, 30% reduction. And physical activity, 10%. तो मुझे लगता है 10% तो बहुत कम है, हम आराम से achieve कर सकते हैं, ठीक है? So these are the targets in context of our country. Basically, it is a repetition of the WHO Global Framework of 2030. So now whenever we have a program and we implement it, then the fund is being given, सबकी training होती है, people are being sensitized, then what? तो unless कि आप कोई reporting रखो, कुछ indicator रखो, so you will not be able to monitor कि इस पे कितना काम हुआ है. Okay, so there are 21 indicators in our national program framework. जो दो इंडिकेटर हैं, they are to mortality, means death, ठीक है? कैंसर एंड कार्डियोवैस्कुलर डिसीजेस एक्सेट्रा. और रिस्क फैक्टर क्या क्या है? अल्कोहल यूज, डायबिटीज, फिजिकल इनएक्टिविटी, रेज्ड ब्लड शुगर, सॉल्ट इनटेक, टोबैको यूज, हाउसहोल्ड एयर पॉल्यूशन एंड लो फ्रूट एंड वेजिटेबल इनटेक, ठीक है? बहुत सारे प्रोफॉर्मा में, क्वेश्चनेयर्स में, थीसिस जहां करते हैं स्टूडेंट्स, दे आर आस्किंग हाउ मेनी फ्रूट्स यू आर टेकिंग डेली. हमारे कम्युनिटी मेडिसिन में एवरी चाइल्ड हु विल पास द एग्जाम, वो सभी फैमिलीज को पूछता है जाके कि भाई आप फ्रूट कितना लेते हो वीक में, वेजिटेबल्स कितना लेते हो, टू असेस द एनसीडी रिस्क. देन कम्स द सिस्टम हमारा रेडी है कि नहीं, हमारे पास फैसिलिटीज हैं कैंसर स्क्रीनिंग करने के लिए, वैक्सीन देने के लिए, मेडिसिन हैं कि नहीं. दिस विल बी अवर सिस्टम रिस्पॉन्स. So the progress for the program will be assessed through these indicators. Now going ahead, I'm sorry, this is not a very clear picture, but basically it is showing the portal जहाँ पे आप data entry करते हो. कोई भी activity हम करते हैं तो हम उसको एंटर करते हैं अपने सिस्टम में. अगर हम हॉस्पिटल में पेशेंट देखते हैं तो एंटर करते हैं, फील्ड में जाते हैं तो फोटोज लेते हैं डॉक्यूमेंट के लिए. सेम वे दिस इज एन इंटीग्रेटेड ऐप जो जाके डिस्ट्रिक्ट लेवल पे इंटीग्रेट हो जाएगा. देयर विल बी द आशा वर्कर, ANM, द नर्स, द MO, द एडमिनिस्ट्रेशन एंड द प्रोग्राम ऑफिसर्स, राइट? सो देयर आर 6 points of data entry. One of our colleagues is doing a research on this portal also. So if used properly, the portal can give us a lot of information about the progress of the non-communicable disease programs. Now I will talk about some of the research which has been done in this aspect, that how the program came into existence and how it is reviewed. Now, this is one of the articles from one of the AIIMS of India, scoping review, right? What they say, हमें किस किस चीज की जरूरत है, challenges. See, patient not aware, multimorbidity, as Dr. Kunal has discussed in detail in his presentation. What is multimorbidity? How it increases the risk of developing the non-communicable disease and also the death from it. Then treatment adherence. Now everybody is talking about awareness, but लोग दवा खा रहे हैं कि नहीं एक बार डायग्नोज होने के बाद. That is the most important point in the prevention program. Then comes the drugs, training, etc. And in the last comes the funding. ठीक है, what is the government funding for the non-communicable disease? So you see what all is needed. You see, you need point of care diagnostic. Okay, you need drugs, you need lab. Then there is another article which talks about the burden of NCDs, right? What they say? They say that there is no integrated approach. There is no implementation of public-private partnership. Now, once this person who is diagnosed at your center, मान लीजिए आपका गवर्नमेंट सेंटर है, टर्शरी कॉलेज, मेडिकल कॉलेज, हॉस्पिटल है, तो पेशेंट फिर भी विश्वास कर लेगा कि एक बड़े डॉक्टर ने उसे देखा. पर यही अगर आशा वर्कर या कम्युनिटी हेल्थ ऑफिसर ने कहा कि आपका शुगर ज्यादा है, आपका ब्लड प्रेशर ज्यादा है, तो वो तुरंत दूसरे डॉक्टर के पास जाएंगे कंफर्म करने. Now these two sectors need to integrate among themselves. Then schools, workplace, community, do we have a system for regular checkup of the people? So these are the gaps for which we need a surveillance system, a collaboration with ministries and a referral system. All these are needed in our program. Now, effectiveness of the NCD program. Now, this article brings forward that we do have healthcare, we do have research programs and health promotion, but definitely the root cause analysis is needed. There's so much diversity in our culture, our socioeconomic status, our education and resource availability, that to study the impact of national programs of non-communicable diseases, we need resources. Now, we can say that this is the crux, what we need at present. See, the integrated approach, health promotion, research-based interventions, what's going to work in a community. जैसे कि anemia program में हम सालों से iron tablets दे रहे हैं, but still we are having the anemia in the community. We don't want non-communicable disease interventions to land up like that. Prevention of exposure towards risk factors. ठीक है. Inclusion of social determinants, empowerment of local people, and early diagnosis with improved capacity for management. So all these are the need of the hour according to this international publication. So concluding the program, I must say that thanks to all of you for listening patiently to me about the policy milestones and the implications of the non-communicable diseases from the international agency WHO to the national agency, that is NCD. Thank you.
Thank you, ma'am, for this wonderful deliberation. As a token of appreciation, I request Dr. Avinash Vyas to kindly present the memento to Dr. Anjali Modi, ma'am. Now, on moving forward, I would like to invite Dr. Bhautik Modi, Assistant Professor in the Department of Community and Family Medicine, AIIMS Rajkot, to summarize today's integrated CME. Over to you, sir.
Good afternoon, all. Hope you have enjoyed the academic feast on non-communicable disease, which is currently the high priority area among all researchers and all implementing agencies. So to summarize the today's CME, we have included experts from the multidisciplinary, different clinical subjects and lifestyle modification part. And we have tried to integrate this approaches for non-communicable diseases to the listeners. So in first session from the CFM department, Dr. Venkatesh Karthikeyan has summarized the global burden of non-communicable diseases. According to them, around 43 million people killed due to non-communicable diseases, and he rightly stated that the need of whole of government and whole of society approach to controlling this non-communicable diseases. In the second session, Dr. Kunal from the Pulmonary Medicine Department summarized the metabolic syndrome and gateway of multimorbidity and stressed that lifestyle interventions, diet and exercise will prevent and reverse the metabolic syndrome. He also stated that if the health systems focus away from the episodic care for acute conditions towards longitudinal, integrated and person-centered care. In next presentation, Dr. Vijayata Madam has, from the OBGY Obstetric and Gynecology Department, has stressed on obstetric transition and global burden of NCDs on maternal and neonatal health. Madam has also stressed that NCDs affecting pregnancy in a larger area, mainly the gestational diabetes, hypertension, cardiac disease, mental health disorder, cervical cancer, thyroid disorder, and their burden and adverse outcomes. Madam has also stressed regarding born too soon and NCDs and preterm birth correlation. Madam has also concluded her presentation with integration of maternal and child health services and non-communicable disease prevention as a road ahead. In the next presentation, Dr. Pradeep Burde sir from Physiology Department has stressed upon lifestyle modifications. Sir stated that daily lifestyle changes greatly improves the health and prevent NCDs. Sir has initiated his presentation with the figure that Indians have a unique body type with more central fat and increased disease risk, and losing 7% body weight and exercising 150 minutes per week cuts diabetic risk by 58%. Sir has also mentioned that visceral fat measurement offers better health risk insights than BMI alone, and concluded his presentation with guidelines highlighting diet, exercise, and stress control, smoking cessation, and cultural practices like yoga to prevent NCDs. And in last presentation, Dr. Anjali Modi from the CFM department, AIIMS Rajkot, has summarized a national program for non-communicable disease globally and efforts from India. Madam has rightly stated the involvement of NP-NCD program and show us the 21 indicators for NP-NCD program. And Madam has also shown us the portal for NP-NCD program in India, and rightly stated that research on national program for non-communicable diseases is of utmost importance. So I conclude the summary of this NP-NCD, and I hope that all has enjoyed this CME and learned a few things and remember a few things about NP-NCD program.
Thank you, sir. Now, at last, I would like to request Dr. Krupal Joshi, Associate Professor in the CFM department, to deliver the vote of thanks.
Thank you, Dr. Krishna. Respected dignitaries, esteemed speaker, faculty colleagues, and dear participants. It's my proud privilege and honor to propose a vote of thanks on behalf of organizing committee of today's CME. My sincere thanks to Dr. Vivek Kumar Sharma, sir, organizing chairperson, for his visionary guidance and leadership in making this CME possible. I also extend my gratitude to our patron, co-patron, member of scientific committee, IT and communication team, and all the colleagues who work tirelessly behind the scene to ensure the smooth execution of the CME. A special word of appreciation goes to our participants who join us in a large number from across the institutional. Your active involvement and enthusiasm have added immense value to this academic event. With these words, I once again thank you everyone who contributed to the success of this CME. Thank you.